No wonder, Mahabharata experience and the others of them.
Ranjit, are we live?
Ma'am.
It doesn't get captured in the picture. It doesn't come. It doesn't look like anything. I know it doesn't look like anything. I can't go, sir. Has to be captured in your mind's eye.
Can I show the CV, ma'am?
Yes, please.
Yes, please.
Getting it right about I function like
Then we have to show you what a staff. What's the point of words?
Yes, ma'am.
Could I request everyone to please mute yourselves? Thank you.
Thank you. Good evening, everyone. Welcome to yet another episode of the Soliloquy series. Today we have none other than Professor Dr. Human Fatemi to give the talk. Before we start, I would like to invite our President of Indian Society of Assisted Reproduction, Dr. Amit Patki, sir, to just say a few words of introduction. Amit, sir, you are there?
Good evening, and at the onset, I would like to thank Professor Fatemi on behalf of ISAR for having kindly consented to be part of this excellent Soliloquy series. We all look forward to your lecture, and we hope that we see you often and we get lots of educative and informative lectures from you and your team. So thank you once again, and I thank the conveners for having chosen such wonderful speakers for this series. So without wasting much time, I would like you all to take this proceedings ahead. Thank you very much.
Thank you, sir. Ritu, is Asha ma'am here? I think
I can't see her. You can just proceed. It's okay.
I would like to introduce our speaker, Professor Human Fatemi, sir. He is the Group Medical Director and Consultant Reproductive Health for Art Fertility Clinics. With a PhD in reproductive medicine and surgery, he has earned acclaim from the European Society of Human Reproduction, as well as the European Board and College of Obstetrics and Gynecology. As a clinical professor at the University of Brussels and visiting professor at multiple esteemed institutions globally, his expertise spans across the field of gynecology, surgery, and reproductive endocrinology. With over 200 plus peer-reviewed publications and a citation report of 4,000 with an H index of 35, he is an esteemed journal reviewer and an associate editor. His profound contribution to the field of reproductive medicine and gynecology include over 300 international conference presentations, as well as numerous prestigious grants and awards. Today, sir will be speaking on one of the most difficult things that we face in ART, that is poor responders. And he will tell us how to evaluate, how to manage poor responders in ART. Over to you, sir. I think we can stop sharing and sir can go ahead.
Okay, so thank you very much for the invitation. Thank you very much for having me. It's a pleasure to be able to present in front of the society. And indeed, Dr. Erika, as you mentioned, this is a very difficult entity, the poor responders. It's a very difficult entity of patients that we are looking at. Now, if you take a look at the number of eggs, basically a woman who is, let's say, pregnant 24, 25 weeks, the daughter, which is unborn, has approximately 7 million eggs in both ovaries. The moment that girl is born, she has 1 million. So you go from 7 million to 1 million. And the moment of puberty, when you start ovulating, basically you have approximately 3 to 400,000. And at the end, you know, you will utilize only a fraction of them, but also most of them will be genetically abnormal. So it's a very inefficient system. Now, at any given age, you can have elevated FSH, you can have normal FSH or elevated FSH. It means the ovarian reserve differs. It means a woman at a young age can be a normal responder, can be a poor responder. Even an elderly woman can be a high responder or a poor responder. Globally spoken, it goes down, but at any given age, you can be high, normal, or low responder. Now, obviously, there are various tools that we are utilizing to understand if a woman is a normal responder. You can utilize your AMH, which is produced by the follicles. You can utilize FSH. You can utilize inhibin B or inhibin A, because they're all working on the pituitary and the central axis. So through these factors, we know that we have a reduction of ovarian reserve. If the number of follicles goes down, we know that the AMH is going down, and this is directly in line with the antral follicle count, which is going down. How is it reliable? What can you use in order to have a better predictive value of ovarian reserve? Obviously, AMH alone is not enough. You need to combine multiple variables. You need to combine the AMH and the antral follicle count. The only problem of AMH is that you have obviously a significant intra and intercycle variation. And of course, you also have assay variation. I always say what you say is what you get. So with a scan, you can see how many follicles you have. And with the more modern scans, obviously, it's very easy to understand it. But as I mentioned, there are significant variations of antral follicle count and also AMH. So the same patient can one cycle have a certain number of eggs, a certain number of eggs, and a certain number of eggs. So there might be significant differences. And it's not that it's going down, it could also go upwards. So this is why we have to be cautious and put intercycle variation into the equation. Now, there have been a couple of diagrams looking into age as a variable, looking into AMH as a variable, looking to basal FSH as another variable, and say, okay, based on these variables, this would be the dose that you would start. But they all have certain shortcomings because, for example, here, the body mass index is not put in equation. So you need also to have body mass index as another variable, which is not always being looked at. Now, when we say poor responders, obviously we want to exclude having a poor response. We don't want to have a high response, because if you have poor response, obviously the chance of getting pregnant is less. And basically, at any given age, the lower the number of eggs, the lower is the chance of getting pregnant. So it's in our interest to maximize the harvest of a number of eggs in order to have the best outcome. Now, what is the prevalence of poor responders? Now, you see, you cannot refer to data published in Israel or data published in UK or different parts of the world, because there is something, it's called geography of infertility. So in different parts of the world, you will face different prevalence of infertility and different prevalence of poor responders. So for example, in the UAE, independent of age, we are dealing with 40% of poor responders. In other parts of the world, it has been described to be up to 25%. Now, ethnicity plays a role. Specifically, Indian women seem to have an accelerated aging of the ovaries. This is what you see, what we have published in the UAE. It's 40% of women have poor ovarian reserve. Now, what is a poor responder? That's the first question. How do you define a poor responder? Do you say if they have less than 3 follicles? Do you say if you have less than 3 or 5 follicles retrieved? Do you look to the estradiol value? Do you look to the FSH? What is an elevated FSH? So there are a lot of different ways to look on the poor responder. If you want to look, is it 7? Is it 10? Is it 12? And so on. So if you start looking worldwide and asking colleagues, what do you think is a poor responder? Everyone will tell you something different. Someone will tell you less than 2 eggs, or less than 3 eggs, less than 5 eggs. Don't use a number of eggs, or you look to estradiol, or you look to how do you treat them, different protocols. So you see, there is a huge heterogeneity. How do we define it? And that's the problem with the poor responders, because it starts already with the definition. What is a poor responder? On the other side, you might have patients who have a good number of follicles, but you stimulate them and you end up with a poor response. So is it the same that a woman who has low number of follicles and has a poor response? So this is why the Bologna criteria came out approximately 12, 13 years ago with Luca Generoli, who came out with a proposal and saying, look, when you have less than 3 eggs or less than 3 eggs, then we talk about the poor responder. And basically you take also the AMH as another variable. So this came out, but then people say, yeah, but we don't agree. Imagine you have a normal patient, young woman, and she has a high AMH, but we don't harvest the number of eggs. So you need to come up with a subcategory of, they call it Poseidon 1 and 2 and 3 and 4, and we will go and look into detail because this has very significant shortcomings. And I think this classification is absolutely wrong, and I will tell you why it's wrong. Why is it wrong? Because let's say you have a woman and she has a certain number of follicles. Let's say she has 7, 8 follicles right, 7, 8 follicles left. And you stimulate that woman with a dose that you think, I don't know, it should be 150, 200, 225. This is one thing that you have to look at, the dose that you administer. Now, the dose that you administer is not the dose which is absorbed in the body and which is present in the systemic circulation. You might get 200 units of a certain FSH. And if you measure your systemic FSH, and I think Dr. Erika has enough experience by working with us, because we always measure the systemic FSH, you cannot have the same value. So you might give 200, your systemic FSH might be 9, you might be 200, and your systemic FSH would be 27. So not what you give is important, how much of that what you have given is active in the systemic circulation. That is important because the metabolism of women differs. Furthermore, there is a difference if the patient has an FSH of 5, 7, 10, or 12. On every unit that your basal FSH increases, independent of AMH and AFC, the response will differ. So the Poseidon has 2 shortcomings. One, they failed to measure the basal FSH as a variable. Because if your FSH is elevated, obviously you have FSH receptor polymorphism, FSH receptor resistance, and you fail to recruit the follicles correctly. So you need to work on the receptors first. You need to enhance the number of FSH receptors. On the other side, let's say the patient doesn't have an FSH receptor issue, but you give 200 units and you expect to have 15 follicles growing. But what if the 200 units that you have given is metabolized rapidly in the body and it's peed out? It goes through the kidney and liver and it's out. So you have no active FSH in the systemic circulation. So that's another shortcoming of the Poseidon criteria. And this is what I just mentioned, which we published with Barbara Lawrence a few years ago. You give the same dose to the patient. One patient has a systemic FSH of 7. The other patient has a systemic FSH of 27. So it's 727 with the same dose of FSH. So not what you give is important, how much of that is active in the circulation. That's important. And that's what many people fail to look at correctly. So even if you take a look at the response, age is another variable. Then you might say, okay, how should we start? Because I know in India, the colleagues, they love what I call biryani cooking. So they give a little bit of this, a little bit of that, and they say this is more good because I'm having this and that, and it's going to be perfect. I think we need to take one step back. We need to understand, when you stimulate someone, you're covering the receptors. Now, we know that with a systemic FSH of 22, 23, you have covered all the receptors. It's like you have 10 lockers. If you give 10 keys, you open 10 lockers. If you have 10 lockers, you give 20 keys, 30 keys, 50 keys, still you will be only able to open 10 lockers. So systemic FSH of 22, 23, you have covered everything. What we know is that there are no differences in FSH receptors, but we can work on the number of FSH receptors. What we also know is that there is a decline of the total testosterone, decline of DHEAS, decline of free testosterone, and decline of androstenedione. But the sex hormone binding globulin remains, as you can see, more or less steady. So this is what we have to look at. Why is testosterone androgens important? Because the higher your androgen level, the more FSH receptors you create. So this is important to realize. So androgens are working on the expression of FSH receptors. So poor responders, they have lower androgens, they have the same number of receptors. So if you would possibly, in theory, increase the number of your androgens, you increase the number of FSH receptors, you might have a better response. And this idea came through old studies where they took male mice
And they transplanted the ovary of a female mouse into a male mouse, and they stimulated, and the male mouse had better response than the female mouse. Why? Because the male mouse had obviously more testosterone production, hence had a better response. So if you work on testosterone androgens, of course, you have to work with aromatase inhibitors, transdermal testosterone, or DHEA. Aromatase inhibitors, obviously, they block the production of estradiol, they increase the androgens, and studies have shown, yes, you can increase possibly the response and reduce possibly the FSH consumption simply because you create more FSH receptors. So you create more FSH receptors, and you reduce the consumption of FSH because the receptors will be more activated. Now, there have been many studies with a lot of heterogeneity looking into the co-administration of transdermal testosterone. And as you can see, there have been some studies saying, yes, maybe you significantly improve your live birth, maybe you significantly improve your clinical pregnancy, you might improve possibly your clinical pregnancy or not, but it's not significant. But you significantly increase the number of M2, and the consumption of FSH is reduced significantly. So basically, these are studies which were published a few years ago, now 10, 12 years by now. The problem is the heterogeneity of these studies. So does it really help? Now, you can see also miscarriage is the same. At the end, there seem to be more eggs and better results. However, if you do a correct RCT, you eliminate heterogeneity and biases, this is what comes out. So this is a recent study which was published by Nikos Polizos a few months ago. And in fact, they gave 2 months of transdermal testosterone. It's a multicentric study. And the summary answer, pre-treatment 5.5 milligram testosterone for 2 months prior IVF stimulation did not increase clinical pregnancy as compared to placebo. That's an important statement. So here you have a correctly conducted RCT with this variable, nothing came out. Important to highlight. And this is the beauty of science, is dynamic. One study tells you this, the other study tells you this, and the difference is because how the study was conducted. We know it reduces the consumption of FSH, that is true. The other factor was DHEA, because you want to create a kind of PCO-like environment, create more FSH receptors. And in the beginning, my good friend Norbert Gleicher and David Barak, they came out with studies that it works like a miracle, that it can be used. And actually, there were some promising studies coming out with the use of DHEA and improvement of embryo quality, improvement of number of eggs, improvement of fertilization, even less miscarriages. So it seemed to be too good to be true. And at the end, what is too good to be true is too good to be true. Because studies looking into that, again, correctly conducted RCTs, they looked into it, and guess what? The 75 milligram of DHEA 6 weeks before IVF did not improve the outcome. So here you see the results. There was no significant improvement at all. So no improvement at all. Now, what about antagonist improved responders versus agonist? Also here, we did not see any difference. What about stop agonist, non-stop agonist? Dimitra Kirou published that. I think I'm a co-author in that paper. Again, we didn't find any difference. All these protocols, as you see, it doesn't make a significant difference. Now, there have been a recent publication, I think it's less than a year ago, where they looked to a flare protocol versus antagonist. Also here, unfortunately, there was no real significant difference in the outcome. Now, some people came out with the idea that we might use growth hormone, because we know in mice who lack the receptors of growth hormone and growth hormone binding protein, the follicular development is significantly impaired. And it works basically on intra-ovarian production of IGF-1, which is important for the follicular recruitment and follicular growth. So people thought maybe growth hormone would add a benefit because it's improving the effect of granulosa cells and the sterigenesis in the cells. So Stratis Kolobianakis published these meta-analysis, and basically, as you can see, it's not touching the unity line. It seemed, again, that growth hormone will add a significant benefit. On the other side, if you take a look at the heterogeneity within these studies, how long did they give it? How much did they give? 24 units, alternate days, 12 units, alternate days, 0.1 per kilogram with FSH, 18 units, day 2, day 4, day 8. So you see, there is a lot of heterogeneity in all these studies. So you cannot really draw any conclusion because of heterogeneity. So what about other factors like different stimulations? Because again, cooking, rec FSH, urine FSH, also here many studies were conducted, and it's the way which company is supporting which study. One company will tell you this is better or the other one is better. At the end, it's the same if you do that correctly. Now, some people were making a statement, you need to add recombinant LH in poor responders. Again, the company which produces recombinant LH did a randomized controlled trial, and they looked the so-called SPART trial. I think in total that 800, 900 patients. And if you take a look at the findings, you see that rec FSH versus rec FSH plus LH, there was absolutely no difference. Adding rec FSH in poor responders did not change the number of retrieved oocytes, neither the outcome. Even the pregnancy rates, nothing was different. Now, one issue that you have with the poor responders is the fact that the follicles are not fully synchronized. And you can imagine if the follicles are not synchronized, you will harvest less eggs, and the eggs that you have might be mature or immature because of this asynchrony. So in order to synchronize them, what you could do, you could try to add E2 priming in order to synchronize, or even start a luteal stimulation. And as you can see with the administration of estradiol, you can synchronize and you have less cycle cancellation. Now, obviously, there have been various studies looking into stem cells and PRP. I will not go into detail because I know in India, many physicians do stem cells and PRP without any backbone, any scientific backbone. But initially, it was Kawamura who came out with a proposal, taking out the ovary, chopping it in pieces, and putting it back, and explaining that this is successful because this is going to improve the results with these extreme poor responders or even in premature ovarian failure. But at the end, it seemed it was not what he has done in the lab. It's the fact that he's chopping up the ovary in pieces. And when you do that, this is creating an aseptic inflammation. It's an aseptic inflammation which increases temporary follicular recruitment with these patients. What about dual stimulation, the so-called Shanghai protocol? You are aware that you can stimulate the follicles at any given time. And it's important to realize that there is something which is called intercycle variation, follicular phase and luteal phase. So it might be that you have more follicles in the follicular phase or you have more follicles in the luteal phase. So this is why it's important that when you stimulate these poor responders, you also explain to them that there might be an intercycle variation, that they might have more eggs at any given time of the cycle, and they need to be ready to be stimulated at any given time of the cycle. This is why the dual stimulation is a valid option to be looked at. Now, Filippo Ubaldi from Rome did beautiful studies. And I think it's interesting. You see, this patient, for example, in the follicular phase, she has 3 eggs. But here in the luteal phase, look how many eggs she has. But for example, this one, in the follicular phase, she has more eggs, in the luteal phase, less. So this is exactly the era of individualized medicine. You see here, this is beautiful. Few eggs, but much more in the luteal phase. Or here, much more in the follicular phase and few in the luteal phase. So this is why you need to look on the patient's profile. And it's not one size fits all. You cannot say, I'm going to do luteal stimulation, you're going to have more eggs than in the follicular phase. No, because there will be cases you have more here, there will be cases you have more there. So it's not one size fits all. It's important to tailor the treatment according to the patient's requirement. Now, last point, and I think this is a very important point, it's a very novel point, is to look at when do you trigger a poor responder? You see, if I would ask you, when do you trigger? Most of you would say we're going to trigger at, I don't know, 17, 18, 19 millimeters. And I would tell you you're wrong. Because you trigger a patient when she's young at the big size follicle, as you can see here. If the ovarian reserve is less, or the patient's age is high and the reserve is less, you can trigger a patient even at the follicular size at 11 to 12 millimeter. You would say, are you crazy to trigger a patient at 11, 12 millimeter? I will explain to you why. You see, when the patient has poor ovarian reserve, what you see is an increase of FSH. When the FSH is increased, first of all, you have a more rapid follicular growth. Secondly, you are expressing more LH receptors. So if you have more LH receptors, you have an accelerated maturation of the oocytes. So the oocytes are maturing much faster. So you have an accelerated maturation of the oocyte because you have more LH receptors and you have a faster growth of the follicle. So this follicle will start ovulating much faster. You see, we do in our fertility clinics a lot of natural cycles. So we gained a lot of experience over the past few years, and we have seen a lot of individual variation among patients. Some patients ovulate at 11, 12 millimeters. Some patients ovulate at 25 millimeters. So it's important to understand at what size do these patients ovulate. But we know the lower the ovarian reserve, the faster they ovulate. Now, I can tell you, this is one of the most important publications we have done over the past few years, because this is very innovative. This was published in Ultrasound Obstetric Gynecology. This has an impact factor, I think, around 9.510. So it's higher than human reproduction and fertility sterility. So it's a really good quality journal. So what we did, we looked at the follicular size of women who are poor responders. We looked at the cycle length, and we looked at the probability of when we do the egg retrieval. And we saw, you see, if you trigger these patients at 11, 12, 30 millimeters, you have almost in 100% of the cases an egg. But obviously, when the follicles become bigger than 15, 60 millimeters, as you can see, the probability of having an egg is gone. So these poor responders, they would have no egg. The eggs would be gone. Of course, you might say, but 11 millimeters, maybe you have an egg, but that egg will be immature. That's true. In 11 millimeters, to be metaphase 2, it's around 60%. At 12 millimeters, you are at 75%. At 13 millimeters, you are at around 80%. At 14 millimeters, you're at around 90%, which is not bad. But then thereafter, again, it is changing the size. But you see, the chance of finding sperm is high, but at the end, the chance of having a mature egg and the chance of having a correct fertilization is the highest around 12, 13 millimeter. And I can tell you from this study, the only pregnancy we had in these extreme poor responders, they came from eggs of 11, 12 millimeters, because they have the best quality of eggs to be fertilized and the lowest chance of cycle cancellation, because all of these patients had an egg retrieval. So poor responders, heterogeneous group. I think it's important that once you cover the receptors with a systemic FSH of 22, 23, that's it. You need to synchronize those follicles because you have an asynchrony. Intercycle variation, you need to look to follicular luteal phase because there might be different between follicular luteal phase. Growth hormone, transdermal testosterone, DHEA, letrozole. You have seen that there is a huge heterogeneity and more studies are required, but important to individualize the time of trigger and to individualize your stimulation based on the patient's physiology. Thank you very much for your attention.
Thank you, sir. That talk was amazing, and it was all that we actually hoped for. More importantly, it was all that I hoped for. And I have a lot of questions, but I think I'll start asking them after Asha madam has given like a summary to the talk and given her viewpoints about your talk.
Thank you, Dr. Fatime. It was a very nice talk, and in short, you covered the most salient points. And the best thing that I liked was about the FSH, that you said that no more khichdi. You have to work logically and use FSH properly. So I like that comment very much. And another thing is about the size of follicle. I think that was the most important thing and biggest take-home lesson, because usually as a standard, we go for 18 to 19 millimeter follicle. But the way you explained was very good, and I think this is something really worth thinking about. So lots of take-home messages and excellent talk. Thank you so much for being a part of ISAR series, and would love to see you more and more. Thank you so much.
Thank you very much.
Thank you, ma'am. So there's one question from the audience which says that suppose in a poor responder, you've done an ultrasound before and you had an antral follicle count of say 4, but you were planning to start the cycle and she did not come and she came the next month, but now the antral follicle count is 2 in that particular menstrual cycle. will you wait? Will you skip that cycle, wait for the antral follicle count to be better, or would you just stimulate in the same cycle?
No, I mean, if she had 4, it means she can have 4 again. What I would do, I would see the patient back in the luteal phase. So I would let her ovulate. I would see her back in the luteal phase because with these patients, you will have a better synchronization of the follicles in the luteal phase. So I will let her be in the luteal phase. If she has, let's say, 3, 4 follicles, then I would stimulate her in the luteal phase of after the ovulation.
Okay. The second question is that what dose of estrogen do you particularly use for estrogen priming before you start the stimulation? Which day of the previous cycle do you start it? And do you stop it and then do you wait for periods? You don't wait for periods, or you just start stimulating?
In fact, we don't do any fresh transfers in most of our clinics because we know that the endometrium is more receptive in a frozen cycle. So the time where we were doing the E2 priming, it was 4 to 6 milligram. And the sooner you do that after the ovulation, the better it is. Because after the ovulation, at day 7 after ovulation, your FSH starts going up. And that's where the follicular recruitment happens. So basically, after ovulation, 6 to 7 days after ovulation is the latest time where you should start the E2 priming if you want to prime and you don't want to do luteal stimulation. We would start a luteal stimulation on day 6, day 7 after ovulation because this is the time where you have the best synchronization. But if you want to go for fresh, then I would suggest you start 4 to 6 milligram in the luteal phase. And then when the patient bleeds the 2nd or 3rd day, you can start with the stimulation.
Okay. Okay. Do you believe in using HMG or FSH over one or the other, or do you think both of them are like REC FSH and HMG? Do you think both are similar, or would you prefer one over the other, particularly in a case of poor ovarian reserve?
The problem with FSH and HMG is that a lot of studies are company driven. You see, there is a lot of company driven studies. I think there are some patients who would benefit from REC FSH. I think there are some patients who would benefit from HMG. I cannot tell you one is better than the other. One group of patients where I would say maybe HMG might be better than REC FSH is the extreme high responders. And it's not the poor responders. On the other side, I think both of them, if they are used correctly, they are equal. So I would not prefer one above the other. REC FSH is much more potent. It's much more efficient. HMG has a lot of variations, but it contains also ACG, which might or might not be beneficial. But the only group of patients where I don't like to give REC FSH are the extreme high responders. So these PCO patients or extreme high responders, those I prefer to treat with HMG. But any other patient, normal responder, poor responder, any other patient, I can treat with REC FSH or HMG.
Now, the thing is that I heard your talk where you say that if your FSH level is 23, 24, that means you have occupied all your FSH receptors. So which day of stimulation do you monitor the FSH level? And if it comes lower than what you want it to be, do you increase the dose of FSH? If yes, then by how many units? And then when do you repeat the FSH? So I know this is a trade secret that I am trying to get out of you, but I really want an answer to this.
I mean, we see back the patient day 5, day 6, but maybe Dr. Erika can elaborate of a case we discussed. I don't know were you here? Were you there, Erika, this morning? No. So we had a patient we were discussing from our clinics in India. That patient received, you see, ESHRE says you should not exceed 300 units of FSH. That's what ESHRE says. So this patient was a normal responder. So she had, I think, 7, 8 follicles right, 7, 8 follicles left, AMH of 2.5 nanogram, normal FSH. She was stimulated with, I think, 300 or 375 of FSH. And we saw back the patient on day 6. She received in the morning the antagonist. So when you receive the antagonist, your own FSH is suppressed. So whatever you measure is the FSH you have administered. And you know, that patient with 375 of FSH had a systemic FSH of 9, which is very low. So we had to go to 450 or even 500
in order to have an FSH of 13, 14 to have a multifollicular recruitment. Now, the question is, what is a good systemic FSH to have a correct multifollicular recruitment? I don't have an answer to that. We are working on AI, but I think your BMI, your basal FSH, and many other factors that we are looking at currently will be predictive on which level of FSH is leading to a good follicular recruitment. And that level might be different. You might have a patient with a systemic FSH of 11 who has a beautiful follicular recruitment. You might have a patient, you need to cover all the receptors, especially these poor responders, with an FSH of 400, 600 even, to reach 22, 23 to have a correct multifollicular recruitment. So I think it's a difficult question, but specific in the poor responders, you want to reach this 22, 23 to cover all the receptors. The problem is you have two phases of follicular stimulation. One is the follicular recruitment, but the moment follicles are 11, 12, 30 millimeters, then before you go for the triggering, you need to reduce the dose. Because if you push too much, you create too many LH receptors. And that would accelerate your nuclear and cytoplasmic maturation, and that would reduce the quality of the eggs and would create more aneuploidy, as we have published recently.
You're on mute, Dr.
Erica, I think I'm going to take the details of the paper from you because I want to personally read it, and I think I'll circulate it as well. Do you believe in a single trigger or do you believe in dual trigger when dealing with women with poor ovarian reserve?
Yeah, we always use dual trigger if the patient is not at risk of OHSS, simply because you see, you have always to look back in nature. So what's happening in nature? In nature, your LH goes up, FSH goes up, but remains high for 2 to 3 days before it's going down. When you give an agonist, what is happening? Your LH goes up and goes down. So you reach your peak in 6 to 7 hours. And then as fast as you went up, as fast as you go down. This is not natural. We say it's natural, the agonist triggering, but it's not. Because FSH and LH are going up doesn't mean it's natural. It is actually against nature, because nature doesn't do this. You see, nature goes up, remains high, and then goes down slowly. Now, the problem is the ACG does more than that. So it goes up, remains up, and then it takes a long time until it's coming down. So this is why I don't like either of them, not ACG, not agonist. So what's the conclusion? You give both of them.
Okay. Also, Dr. Fatemi, by the virtue of working in the same city as ART fertility clinics, I've seen a lot of files come with HCG being given from the second day of menstrual cycle itself in some protocols. A very small dose of HCG is being given in women with poor ovarian reserve. I couldn't see that point in your presentation. So if you could tell me something about that, I would really like to learn.
Yeah. You see, some patients have disturbed steroidogenesis, so they don't produce enough estradiol per follicle. I don't think by giving ACG from the beginning would add any benefit, but from follicular size of 9, 10 millimeters, where you have enough LH receptors being expressed, with administration of ACG, you would promote the steroidogenesis and possibly work on the egg quality. It's not a miracle, but some patients might benefit from that. So when we add ACG, it's not with all poor responders, it's specifically in patients who have low E2 per follicle being produced. So we would enhance the steroidogenesis.
Okay. Okay. Erica, do you think you have any questions? I'll go back to the audience and then check on questions. Asha ma'am, if you have any questions, I'll just take 2 minutes to go back and.
Do you believe in hormonal estimation for all patients before starting the ovarian stimulation like FSH, LH, E2, or you just rely on your ultrasound findings?
No, for us, the endocrine profiling is extremely important because these basal values are predictive of the response. They are predictive also in normal responders because you might have a normal responder who might have an FSH receptor polymorphism. So it's teaching us the time of trigger. We never trigger a patient of the same size. If they have modified LH levels, we trigger them later. If they have low LH levels, we trigger them different. High FSH, low FSH. So we look to all these basal values, and also the basal progesterone for us is a reflection on how we have to stimulate and at what size we have to trigger that patient. So every value of these hormones is teaching us to individualize that patient.
So how often do you repeat? Like you have done the basal, then again you'll repeat on the day of antagonist or just on the day of HCG?
So basically, we do day 2, day 3. If we do a normal follicular stimulation, and then we see back the patient on day 6, so we measure. And then antagonist is an average 9 days, so we measure again on day 9 or day 10 before we trigger. So based on these 3 measurements, we try to individualize the treatment according to the patient's requirements.
Thank you. Yes, Ritu, if you want to ask anything, any new questions that have come up?
Yes, so there's a question from the audience which says that sometimes during stimulation, they get stuck at a follicular size of 16 to 17 mm. And no matter how much they amp up the dose of the gonadotropin, the follicles just don't budge in size. I somehow know the answer to this, but I would ask you to tell me the answer for the audience.
I mean, it depends what kind of patient you have. Poor responder, normal responder, what are the basal levels? How many receptors are there? Are you covering correctly the systemic FSH values? Maybe this patient you should have triggered much earlier. Maybe you have passed the time of trigger. So there are many various points that you need to look at before answering this question. But if the follicle doesn't grow, it means that the receptors are not being stimulated, and possibly that the patient has already changed going from follicular phase towards the luteal phase. Maybe she's luteinizing at that time. So one needs more information to answer this question. But normally, if the follicle doesn't grow, it means you push it too much. You should have triggered it much earlier.
Do you believe in using clomiphene citrate along with gonadotropins in women with poor ovarian reserve?
Again, this is what I call biryani cooking. Yes, you can cook biryani. You can cook it on various methods. Is there any scientific evidence? I don't know. I'm not aware of it. In Japan, they do it often. I had a lecture tour in Japan a few months ago, and I know they do that quite often. What would clomiphene citrate do? Obviously, there is a beautiful publication by Johann Smits from Brussels. I think it's end of 1980s. It increases your LH, systemic LH production. And Al-Inani published another paper. It prevents you of ovulating. But except that, I don't know whether it's beneficial to do that. So I'm not a big fan of these cooking techniques.
Or there's another question where they say that when they have triggered at 17 to 18 mm or 16 mm, they've got lesser lesser M2s and more M1s. Can they do something differently in the next stimulation cycle to increase the number of M2s that they retrieve from the same person?
I mean, the slides of the paper I showed to you is in a poor responder is even 16, 17 is too late. But again, poor responder is not equal poor responder. You might have 2, 3 follicles. You have a basal FSH of 12 or 13, or you might have a basal FSH of 5 or 6. You might have 2, 3 follicles. You might have a short cycle. You might have a long cycle. I think the cycle length and basal FSH are the biggest predictors on when to trigger that patient. So it's not that you say I have a poor responder, I'm going to trigger at 16, 17, or 12 millimeters. I think all these variables play a role in order to decide when to trigger. So if you have triggered at 16 millimeters or 70 millimeters and you see the egg is not mature, obviously then you have to see what is the progesterone per follicle produced, because progesterone per follicle is a reflection of number of LH receptors you have created. So if you have created enough LH receptors, then your progesterone goes up. In nature, before the patient is ovulating, there is a small progesterone rise before LH goes up. Why does it happen? This is giving a signal to the pituitary, I have created enough LH receptors. Because you need to have these LH receptors in order to go through the final oocyte maturation. And that's the only purpose of that progesterone. That's a sign you have created enough LH receptors. So progesterone is an indicator to say, I am ready.
So if you stimulate a woman and you have low progesterone, you will end up with a lot of immature eggs. If you stimulate a woman and you have a lot of progesterone, then you would be too late to triggering. You will have post-mature eggs. So this is why it's important that you look into the progesterone per follicle before you trigger.
Okay. I think I've asked all my questions and all
I have
the audience.
one last question, sir. But in extreme poor responders, uh, when the basal FSH in this cycle is very high, do you recommend postponing it to another cycle and keep checking basal FSH, or can we?
I mean, it depends which kind of poor responder you have. If it's such an extreme poor responder where she has only one follicle every time, it doesn't make any difference. But if it's a patient who might have 2, 3, 4 follicles, then I would change it, yes.
And with
What
these
is
patients,
what is the cutoff of FSH that y'all keep before starting the stimulation?
You know, if a patient has a significantly elevated FSH and a monofollicular recruitment, we don't stimulate those patients. We go for what we call a managed natural cycle. So we let the follicles being recruited, we let the follicles, let the body do the job. Once those follicles have a size of, let's say, 9 to 10 millimeters, we give a little bit of FSH, a little bit of antagonist, and we trigger. So we call it the managed natural cycle Timur protocol.
Okay.
DK,
Thank you so much for this wonderful lecture, sir. And I think huge take-home points of FSH monitoring and early triggering in poor responders, and none of the other extras working very well, including the
No
stuff.
biryanis.
Yeah. Thank you. Over to you, ma'am.
okay. Thank you very much for
Thank
having
you.
me.
Thank
Okay.
you, sir. Thank you for coming for this program. I am sure our audiences are as ecstatic as I am, because there's so much of knowledge that has been imparted today. And I'm excited to use it in my practice. I'm sure the audiences are equally excited to use it in their practices. And hopefully someday we can get back to you and tell you how you've changed our practice in a day-to-day basis. Thank you so much,
Excellent.
sir.
Appreciate your feedback and appreciate the invitation. Thank you very much.
Thank you, sir.
See you. Bye-bye.
Good night, sir.
Can I stop them?
Yes, please. Thank you.
Welcome.
मैम अच्छा था ना आपका